So I have been assigned the topic antiviral treatment for severe respiratory diseases, and I will focus only on seasonal flu and COVID-19. And I don't have any conflict of interest to declare. So this is just a schematic diagram showing you the different phases in COVID-19. So beginning with the viral replication phase, and the virus usually peak between day 3 to 5, and then most patients that deteriorate occur in the second week of the illness, presumably due to cytokine dysregulation. So antiviral drug, if given early, hopefully can do something to prevent the subsequent deterioration due to cytokine dysregulation, but it's not so simple in reality. This is a study recruiting 250 subjects, 100 critically ill, 100 hospitalized patients, and 50 outpatients. And the investigator found that the SARS-CoV-2 viral RNA load in the plasma are associated with more critical illness in COVID-19. And they also noticed that the viral RNA load in the plasma correlates with key signatures of dysregulated host responses. So you can see on the right-hand side a number of inflammatory mediators in high concentration with correlation with the viral RNA load. So this suggests a major role of uncontrolled viral application in the pathogenesis of this disease. The same group of investigators also looked at more ICU cases admitted between 2020 and 2021, and they looked at the RNA of the SARS-CoV-2 nucleocapsid region 1 identified in the plasma samples within 48 hours from the admission. And they noticed that those with higher viral load have actually much higher 90-day mortality compared to those with lower viral load. So you can see that the 90-day mortality was 52% for those with very high viral load, and then those with low viral load, they have 26% 90-day mortality, compared to only 17% in those who have less than 1 copy per mil, almost nothing. So again, high viral load is associated with worse outcome. Now there are 2 RCTs looking at the role of remdesivir in COVID-19. So on the left-hand side is the WHO Solidarity trial. And basically it shows that patients who are receiving oxygen, whether low or high flow, but not yet ventilated, they are the ones who actually best benefit from taking remdesivir. It actually reduces the mortality risk. On the right-hand side is the NIH ACTT1 trial. They have noticed that those receiving oxygen also would recover faster compared to other categories. For example, those who require high flow O2 or NIV or even on intubation. So those receiving oxygen tend to have better outcome on remdesivir. And there are other real-world observational data for the use of remdesivir in hospitalized patients. So this is from a large cohort in the USA, a large number of patients receiving remdesivir matched to those not receiving remdesivir. So B represent patients do not require nasal oxygen, C, those require low flow O2, and then D, high flow O2 or non-invasive ventilation, and then E, invasive mechanical ventilation or ECMO. The investigator shown that remdesivir actually reduced mortality in all subgroups in this case, but this is only observational data. And the same group of investigators also looked at the ill patient. So they have patients admitted between 2020 and 2022, and they actually matched to patients not receiving remdesivir during the hospitalization. And they noticed that remdesivir is associated with significantly reduced mortality among those hospitalized for COVID-19 requiring O2 on admission, and including those requiring high flow nasal oxygen, non-invasive ventilation, IMV, invasive mechanical ventilation, or ECMO, with severe or critical disease across different variant period. So on the right side, you can see the data. So low flow oxygen, and then high flow, and also including non-invasive ventilation, and those who require invasive ventilation or ECMO, all benefit from the use of remdesivir. But this is, again, observational data. Now, the ACTT trial actually had a post hoc analysis, and they noticed that oxygen is only one factor that predicts the better outcome from the use of remdesivir. If you take into account other factors like a low platelet count, a low absolute lymphocyte count, a low neutrophil count, they also contribute to the outcome. So if you take into account all this risk profile, you can see the area under curve is much greater if you include more than O2 requirement as the predictor. So you need to take into account other markers, low platelet, low neutrophil counts, or lymphocyte count. Now, this study also conducted in the US in the cohort, and they have shown that remdesivir reduced mortality in immunocompromised patients hospitalized for COVID-19 across different variant waves. So they have a large number of patients receiving remdesivir compared to those who did not receive. And they have shown that the 14-day mortality actually was reduced by 30% for those taking remdesivir. And for the 28-day in-hospital mortality, it was reduced by 25%, comparing those who received remdesivir and those who did not. So these are the data. So whether it's pre-Delta period, Delta period, or Omicron period, they all benefit from the use of remdesivir. So this remdesivir actually reduced mortality of immunocompromised patients across different variant waves. So the good news is that despite the changes in the spike protein of all the variants, antiviral activity actually is quite well preserved against Omicron and other variants. So you can see the EC50 is actually more or less the same when you look at the antiviral drug and the dealing with different variants. So we still have effective antiviral treatment. And more data also has been reported by another group recently. Despite the fact that XBB is the varying variant circulating worldwide, there is certainly more immune evasion. So you can see the recipients of the vaccine, they have lower antibody level to XBB and other subvariants. But then when you look at the in vitro inhibitory activity of all the antiviral drugs against all the subvariants, it is actually quite well preserved. So this is actually good news. Now, antiviral combination has been reported by several groups. So this is one example, a patient with B-cell acute lymphoblastic leukemia and COVID-19 had persistent progressive pneumonia for about 5 months, despite initial treatment with monoclonal antibody, intravenous remdesivir, and prolonged steroid. And then out of desperation, they actually tried 20 days of Paxlovid and 10 days of IV remdesivir. And surprisingly, the viral load dropped quickly. So you can also see the radiographic improvement with the combination treatment. Now, this is, of course, no placebo control, right? There's no control. But there are also other case reports suggesting that the combination therapy may be useful in patients who are severely ill and they are immunocompromised. So this is actually worth further exploration in proper RCT. So for the part on the COVID-19, remdesivir benefits occur more in those with less severity. So those requiring O2 on admission based on our RCT data. And the benefit probably is not as much in those with critical disease, for example, requiring high flow O2, IMV, or ECMO, despite the fact that they have higher levels of viral load. And the disconnection between the detectable virus and response to antiviral in the more severe cases is likely due to cytokine dysregulation. So the antiviral combination is worth exploring by the RCT design, especially in those who have severe disease with immunocompromised conditions. And the severe critical cases very often would require immunomodulating agents, which will be addressed by the next speaker. So this is, again, another diagram showing you the different category of severity, and those who require O2, they would benefit from the use of a good range of immunomodulating agents. I think Paul will address this. Now we turn to influenza. So currently we have a number of neuraminidase inhibitor. So oseltamivir is readily available. We also have inhaled zanamivir. IV peramivir is not as readily available compared to oseltamivir. And baloxavir has become available in oral suspension or capsule. Now, the antiviral for patient hospitalized with influenza, there has been no antiviral demonstrated by RCT with placebo control to be effective in patient hospitalized with influenza. In fact, it would be difficult to get ethical approval to have an RCT and placebo control. So by default, oseltamivir actually has become the standard of care. So it would be, I think we will never see RCT compared to placebo. But anyway, the peramivir, oseltamivir in double dose versus standard dose, and baloxavir on top of oseltamivir have been tried, but all negative in terms of clinical outcomes. However, oseltamivir has been shown to be effective in a lot of cohort studies. So this is just one example, published by Alison McGeer in 2007. So patients receiving oseltamivir have a much lower risk of mortality. So this is cohort data. We also have some data from hospital cohorts combining 3 sites, Hong Kong, Singapore, and Beijing, published a few years ago. And we noticed that NAI actually reduced risk of death in adults hospitalized with influenza. And the best survival actually would occur if NAI is given within 2 days. But even if you start a bit late, like within 3 to 5 days, there is still some benefit. Now, if you look at the community data based on open label pragmatic RCT design, there's one published in 2020. And because they are all community outpatient with mild disease, so you can only conclude that the use of oseltamivir only reduced the duration of symptom by about 1 day. But these are very mild cases. Okay. And then there are also more mild community data, this time on the use of baloxavir. So when compared to placebo, baloxavir actually shortened the time to alleviation of symptoms, so by 26.5 hours. Okay. When you look at hospital data, there's one meta-analysis showing that the use of NAI could actually reduce mortality risk. If you use it early, you have better benefit. And even if you use it early, it's better than use it late. So if you use it within 2 days, you get the best result. And then there are also the cohort study looking at critically ill patients. So early use of oseltamivir actually could lower mortality among patients with influenza A, H3, and 2. But there was no effect on mortality observed for H1N1 and influenza B. And then a few years ago, there was a meta-analysis based on 9 studies sponsored by Watch, and it was quite favorable. So if you look at the intention to treat population, infected population, the medium time to alleviation of symptoms was actually much reduced compared to those receiving placebo. And there was also fewer lower respiratory tract complications requiring antibiotics in those who receive oseltamivir, and fewer attendance to hospital for any cause. And the side effects include nausea and vomiting. Now, however, just a few months ago, there was another meta-analysis, and they add on about 7 more studies, so 15 studies in total. And the observation is totally negative. Tamiflu not associated with reduced risk of hospitalization, not associated with reduced hospitalization in the older population. And also the only thing that is consistent is the nausea and vomiting for the side effects. So we actually look at the data in a bit more detail. And there are at least 3 rebuttals coming out in 2 days' time. And one is from myself together with Tim Yuiki and Nelson Lee. So we noticed that the investigator actually put in a lot of mild cases with mild endpoints. So they look at time to alleviation of symptoms. And many of the cases actually were uncomplicated influenza. And none of the RCTs were actually powered to assess the endpoint of hospitalization. And they include many patients without increased risk for severe influenza. Okay, and overall, the hospitalization rate in the untreated control was very low, 0.6%. And basically, the number is underpowered to address the issue whether oseltamivir could actually reduce the risk of progression to severe disease. So really, if you want to see the role of oseltamivir, you need to have a very large size RCT. The estimated size is between 15 to 30,000 patients. And you need to recruit the high-risk patients, okay? So adults, those who have comorbid illness. But you will never see this, you know. So until data from such a large RCT are available, I think early oseltamivir for treatment of adults with influenza at increased risk for complications will continue to be recommended, you know. Now, what about higher dose of oseltamivir? So we actually have tried double dose of oseltamivir compared to standard dose 10 years ago. And basically, there was no advantage of using double dose over conventional dose for influenza A, H3N2, or the pandemic H1N1. But we did notice that the higher dose actually improved viral clearance for influenza B. So you can see the viral load drop much quicker for those who received double dose. And this was because the IC90 for influenza B was actually much greater, okay? But at the end of the 5-day treatment, we noticed that 40% of the severe cases still have positive PCR. So I think treatment with NAI for more than 5 days would be necessary in some severe cases. And when we look at the other publications, Jeremy Farrar actually published in 2013 from the Southeast Asian Network. He also observed no difference in viral clearance and other endpoints between standard dose and double dose. And there was one study by Anand Kumar in the Canadian ICU cohorts using triple dose compared to standard dose, and he did not find any positive outcome, basically. And because of the small sample size, it did not come out as a full journal paper eventually, but it was reported in the ICAP. What about triple therapy? Well, triple therapy has been tried by my friend John Bagel of NIH. So he was using oseltamivir, amantadine, and ribavirin, so targeting 3 different mechanisms compared to oseltamivir monotherapy in the phase 2 trial. So he noticed that patients on the combination therapy, more of them actually have detectable virus compared to the placebo. So less of them actually have detectable, 40% compared to 50%. 50% on the monotherapy, and 40% of those using triple therapy have detectable virus. But in terms of clinical outcomes, none was positive. So you do have a faster clearance for the virus, but you don't achieve clinical endpoints. Again, I think it's because of cytokine dysregulation, you know. And the triple therapy group also have more side effects, mainly GI related, like nausea and diarrhea and vomiting. And we also have data combining favipiravir and oseltamivir. So favipiravir is the polymerase enzyme inhibitor. So this is a study comparing 2 cohorts enrolled in prospective studies of oseltamivir monotherapy or combined favipiravir and oseltamivir. So these patients were hospitalized with influenza, and they actually had respiratory failure. And some of them actually require invasive mechanical ventilation. And the time from symptom onset was within 10 days. Basically, those who received the combination treatment, more of them could achieve 2 points drop in the 7-point ordinal scale. The proportion of undetectable viral RNA at day 10 was also higher in the combination group compared to the oseltamivir monotherapy. Now, however, the clinical endpoints like mortality, other outcomes, there were no significant differences. So the combination treatment may accelerate clinical recovery compared to oseltamivir monotherapy in severe influenza, and it should be formally evaluated in RCT. That is the conclusion. And of course, we also have new drug, so baloxavir, a polymerase enzyme inhibitor, combining with oseltamivir compared to oseltamivir alone. And in terms of the primary endpoint, which is the clinical endpoint, there was no difference between the two groups in terms of time to clinical improvement. But the study limitation was that there was delayed use of baloxavir. So only about 39% of the patients received baloxavir within 48 hours of symptom onset. So that may limit the efficacy. And in terms of the virology endpoint, again, it is better. The combination treatment clear your virus faster, but you don't get good clinical endpoint. Again, I think it's likely cytokine dysregulation. So for severe seasonal flu, oseltamivir appear effective in reducing mortality in hospitalized patients if given early based on cohort studies. I think it would be unlikely to have for anyone to conduct RCT of oseltamivir with placebo control or a large sample size for severe cases. The combination antiviral lower viral loads more quickly, but do not improve clinical endpoints. I think it's because of cytokine dysregulation. But I think more RCT on timely use of antiviral combination should be needed. And we also need to look at the adjunctive role of immunomodulating agents, which will be addressed by the next speaker. Thank you for your attention.
Can we have a question? So Raja first. Thank you.
Lovely talk. Thank you. I got a couple of questions for you. So in COVID, we had favipiravir and molnupiravir prescribed sort of throughout India in huge numbers, massive numbers. And it was mainly in mild cases. And the analogy that you drew with influenza, which is sort of mild cases, not much effect, is something we saw both in favipiravir and molnupiravir. So my question was, do you think there's still a place for antiviral treatment in patients with COVID as things stand today? So that was one question. The other question I had was about drugs like antibiotics, but drugs like azithromycin, doxycycline, etc., which also seem to have an antiviral effect along with having an anti-inflammatory effect, which also got prescribed quite a lot in COVID. So my question was, do you think there's a place? And if there is, do you think there's a similar scenario that might happen in diseases like influenza and other respiratory viral illnesses where patients come into hospital?
Okay, thank you for your questions. So the first question is on the role of antiviral for COVID-19. Well, clearly remdesivir works, especially for those who require supplemental O2. And so, again, of course, those who are already in severe respiratory failure in ICU, they may not benefit too much. They already got cytokine storm and they need the immunomodulating agents. But for those who require low flow O2, clearly there's a good benefit. For the use of immunomodulating agents like clarithromycin, azithromycin, we do have data for influenza. So in 2015, Nelson Lee and I actually compare oseltamivir plus azithromycin versus oseltamivir alone. And we found that the cytokines actually reduce more quickly with the combination treatment, but we did not see good clinical endpoints. And Ivan Hong actually has a triple therapy regime for severe influenza. So he used oseltamivir plus clarithromycin plus naproxen, NSAID, compared to oseltamivir alone. And he published in Chest showing that the triple therapy actually lower 30-day mortality and also reduce the emergence of mutants. So for flu, we do have some data. For COVID-19, I think we need more information.
There's a question here in the front. Yeah.
Yeah, I have a very similar question. As a clinician, you always battle with this kind of issues, right? Just to add on from what you had just mentioned, can you just make a quick comment on steroid?
Serum.
Steroids.
Oh, steroid, okay.
Yeah.
Now, steroid for COVID? for flu, okay. Well, because of the limit on 25 minutes, I actually removed a number of slides. There was actually a meta-analysis published in 2019 showing that patients with influenza who receive steroid have a 3-fold increase in mortality. And then in Beijing, Dr. Chao Bin looked at H7N9, and those who receive steroid also have higher mortality and higher viral load. And he further looked into the dosage. Those who receive higher dose, like methylprednisolone, 150 milligram equivalent or more, it was associated with worse outcome. And those who receive less than 150 milligram methylprednisolone equivalent, they appear to have not neutral outcome. So I think we need to look at the dosage. We know that for CAP, the severe CAP in ICU, the use of adjunctive steroid would improve outcome because they are already covered by very potent antibiotics. But for viral disease, I think we need more information.
For questions online, the post-exposure of the antivirals for influenza, back to get in early, as soon as they've been exposed, the place of post-exposure initiation of antiviral for flu.
Well, certainly if there's nursing home outbreak, now we use a fair bit of oseltamivir prophylaxis.
Does it make a difference? Does it work?
If you do it in the ring manner, it appears to work in some cases. Now, baloxavir is actually being tried in domestic contact, whether it can reduce domestic transmission, and the study is still in progress.
Okay, thank you. I don't have any more online. I don't think there's any more here in the room. I think that's all done. Thank you.